Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. On this episode, I will continue our discussion of lymphoma for radiology board examinations. If you haven't checked out part 1 on lymphoma yet, please go ahead and check that out. Thank you for listening to this podcast, and also thank you for all the good that you do in medicine. Without further ado, let's get into this episode. First question. The most common extranodal site for non-Hodgkin's lymphoma is what organ? What is the most common extranodal site of non-Hodgkin's lymphoma? The answer is that the stomach is the most common extranodal site of non-Hodgkin's lymphoma. Next, what are typical imaging features of gastric lymphoma? Think for a moment, what are typical imaging features of gastric lymphoma? Gastric wall thickening without gastric outlet obstruction is typical for gastric lymphoma, even when extensive wall thickening is present. Note that primary gastric lymphoma is mucosa-associated lymphoid tissue, otherwise known as MALT, M-A-L-T, mucosa-associated lymphoid tissue, because the stomach has no intrinsic lymphoid tissue. Both gastric lymphoma and gastric adenocarcinoma can cross the pylorus into the duodenum. Gastric lymphoma can also have a linitis plastica, or leather bottle appearance, which can also be seen with infiltrative metastatic disease, such as from lung, breast, or other metastatic cancer. Compared to lymphoma, gastric carcinoma is more likely to present with a focal mass that causes gastric outlet obstruction. Lymphoma tends not to cause gastric outlet obstruction. On a more detailed level, gastric lymphoma is typically either extranodal marginal zone lymphoma, which has homogeneous wall thickening with perigastric lymphadenopathy, or else diffuse large B-cell lymphoma, which has gastric wall thickening that can be really thick, typically greater than 4 centimeters in thickness, with additional lymphadenopathy. But to recap, the most likely way that gastric lymphoma may potentially present on a board exam would be gastric wall thickening without gastric outlet obstruction. If you do see that gastric outlet obstruction, you should probably consider gastric adenocarcinoma first. Also key is the linitis plastica appearance of the stomach. If you don't know what this looks like, look it up. It can be a manifestation of diffuse lymphoma involvement of the stomach or diffuse metastatic disease from other malignancies to include lung and breast cancer. Next question. What is most common, gastric adenocarcinoma or gastric lymphoma? Gastric adenocarcinoma is most common, and gastric adenocarcinoma comprises about 95% of gastric cancers, whereas lymphoma comprises the majority of the remaining 5%. So gastric adenocarcinoma is much more common. You should also remember a gastrointestinal stroma tumor, because these can also occur in the stomach, and these have typical imaging characteristics with smooth margins, typically without lymphadenopathy. So if you see a smoothly marginated mass in the stomach without lymphadenopathy, consider gastrointestinal stromal tumor as well. Next, does H. pylori infection increase one's risk of gastric lymphoma? Hopefully this is an easy question, because the answer is yes. H. pylori raises the risk of both gastric adenocarcinoma as well as gastric lymphoma. That is why it can be very important to test and appropriately treat H. pylori infection, because it is carcinogenic. It also can cause problems with ulcers, as we know. Chronic H. pylori infection causes gastritis, and over time, this inflammation can cause the mucosa to gradually acquire the lymphoid tissue, which is, again, our mucosa-associated lymphoid tissue, or MALT, M-A-L-T. That is then at risk for monoclonal proliferation. Interestingly, low-grade MALT lymphoma can sometimes be cured simply by eradicating the H. pylori, and that is something I think you should be aware of for radiology board exams. If the H. pylori is untreated, you can progress from low-grade lymphoma to aggressive gastric lymphomas, such as diffuse large B-cell lymphoma. So it is important to identify and treat H. pylori infection, and it can sometimes even potentially cure a low-grade lymphoma based on what I've read and understand. Next, what is a classic appearance for mesenteric lymphoma? Mesenteric lymphoma can present with confluent, lobulated, homogeneous soft tissue masses that encase mesenteric vessels. I will say that one more time. Mesenteric lymphoma presents as confluent, lobulated, and homogeneous soft tissue masses that encase mesenteric vessels. Mesenteric lymphoma has also been termed as presenting with the sandwich sign, which derives from soft tissue masses that sandwich the mesenteric vessels. So you see the soft tissue masses surrounding the vessels, that is the sandwich sign within the mesentery. With mesenteric lymphoma, you can see fat between the mesenteric mass, and mesenteric masses may distort surrounding structures, but they typically would not occlude those structures with lymphoma. That is a common theme, whether it be the ureters, whether it be the stomach, whether it be the bowel, or now whether it be structures in the mesentery. Lymphoma typically does not obstruct or occlude these structures. And for mesenteric lymphoma, non-Hodgkin lymphoma is most common. Next question. What is Misty mesentery, and is this a sign of potential lymphoma? Misty mesentery manifests as fat stranding in the central mesenteric fat. I suspect you've all seen this on CT examinations at this point. If not, look up Misty mesentery so you know what this looks like. Misty mesentery is a sign of lymphatic insufficiency and is most commonly seen in middle-aged males and is typically stable over time in idiopathic, inflammatory, or related to portal hypertension. So most commonly, misty mesentery is not a sign of malignancy. However, if you see misty mesentery as well as abnormal lymph nodes, this is suspicious for lymphoma. Misty mesentery can also less commonly result from lymphatic infiltration from other cancers, such as a metastatic GI malignancy to the abdominal lymphatic system. Next, what is the deal with Burkitt lymphoma? Essentially, I want you to think of a few high-yield facts about Burkitt lymphoma. Burkitt lymphoma is a very aggressive B-cell lymphoma, meaning it grows rapidly. And when I say rapidly, I have read that aggressive B-cell lymphomas that are Burkitt lymphomas can double in size in 24 hours. That is really impressive. Burkitt lymphoma also has early metastatic disease. So often Burkitt lymphomas will present as large and metastatic masses. Unfortunately, Burkitt lymphoma is the most common type of non-Hodgkin lymphoma in kids, but fortunately, children have a good prognosis with Burkitt lymphoma if they receive appropriate chemotherapy. Adults, however, with Burkitt lymphoma typically have a worse prognosis than kids. Burkitt lymphoma is much more common in Africa, and it is much more common in boys, so you can look for that in a question stem to help you identify Burkitt lymphoma. Endemic Burkitt lymphoma in Africa is highly linked to Epstein-Barr virus infection and or malaria infections, so also look for that history and be aware. for a potential follow-up question that Burkitt lymphoma endemic in Africa is linked to Epstein-Barr virus and or malaria infections. Burkitt lymphoma can also happen with HIV or immunosuppression, such as in organ transplantation. Next question. For residents out there, this may require thinking back to some of your medical school training or intern year training. What are B symptoms? That is B like boy. What are B symptoms? B symptoms with lymphoma are fever, night sweats, and weight loss. When I say weight loss, this can be defined as an unintentional weight loss of greater than 10% of a person's body weight in 6 months. Lymphoma commonly presents with B symptoms, so look for these in a question stem on your board exams. Additionally, B symptoms result from elevated inflammatory cytokines, so tuck that away. Next question, do B symptoms have prognostic implications? The answer is yes. If B symptoms are present, this generally predicts poorer prognosis for lymphoma patients. Under the Lugano classification system, lymphoma is upstaged or staged higher if B symptoms are present. So the presence of B symptoms is typically not a good thing, and it generally predicts a poorer prognosis. Next, what is the Lugano classification system for staging of lymphoma? The Lugano classification system for lymphoma stages lymphoma based on 2 main divisions, whether the disease is limited disease or advanced disease. So 2 main pathways under Lugano, limited or advanced. You can look up the details elsewhere, but in general, limited disease is basically lymphoma in only a few lymph nodes on the same side of the diaphragm, and advanced disease has lymph nodes on both sides of the diaphragm. This is very similar to the older Ann Arbor staging of lymphoma that I learned in medical school. If you have disease on both sides of the diaphragm, that denotes that this is advanced disease based on the Lugano system. Limited disease in general is stage 1 and 2, and advanced disease is stage 3 and 4. I'm going to leave it at that for now. I'm not sure how detailed they would get in asking questions about the Lugano classification system, but you should at a minimum be aware that this is a staging system for lymphoma, and I would also be aware that stage 3 and 4 generally means that you have lymph nodes that are abnormal on both sides of the abdomen. Whereas if you have lymph nodes only on one side of the abdomen, especially if they show you an image that only has a few lymph nodes, this would be limited disease, which is lower stages, either stage 1 or stage 2. Next question, can you have stage 4 lymphoma without having lymph node involvement? Think about this question for a little bit. Can you have stage 4 disease if your lymph nodes are not abnormal? The answer is yes. Stage 4 lymphoma may or may not have lymph node involvement of disease, but it would require, if there are not lymph nodes, that you have diffuse involvement of at least one extranodal organ or extranodal disease that is too extensive to be treated with radiation therapy. Next question. What is the size cutoff in the Lugano classification system for a lymph node to be considered as bulky disease? Okay, Lugano makes a special qualifier for what they term bulky disease, and that has a specific size cutoff. Some of you may know this. I'm guessing a lot of you don't, so don't feel bad if you don't know this, but at least you'll hear it once from me. 10 centimeters is the cutoff size. So if a lymph node is greater than 10 centimeters in diameter, this is considered bulky disease per Lugano classification of lymphoma. Next, what is more common, Hodgkin lymphoma or non-Hodgkin lymphoma? I do think this is an important question. You have a 50-50 shot. What is more common, Hodgkin lymphoma or non-Hodgkin lymphoma? The answer is that non-Hodgkin lymphoma is more common and comprises about 2/3 of lymphoma cases, whereas Hodgkin lymphoma comprises the remaining 1/3 of lymphoma cases. Non-Hodgkin lymphoma is more common at about a 2/3 to 1/3 ratio compared to Hodgkin lymphoma. True or false? Hodgkin lymphoma is curable in most cases. Again, you have 50-50 odds. Is this true or false? Is Hodgkin lymphoma curable in most cases? The answer is yes or true. Hodgkin lymphoma is curable in about 90% of cases. What is the pathologic hallmark of Hodgkin's lymphoma? Think back to medical school. Think back to the USMLE exams. What is the pathologic hallmark of Hodgkin's lymphoma? The answer I'm looking for is Reed-Sternberg cells. Reed-Sternberg cells are the histologic hallmark of Hodgkin's lymphoma. I think that fact is just worth repeating in case that were to come up in a question stem. That is enough for now. I will continue this discussion on lymphoma on the next episode. Thank you for listening. I appreciate the time that each of you spends listening to these episodes to prepare for your radiology board examinations or for other educational purposes. If there is anything I can do to improve the podcast, do not hesitate to reach out to me at radrevpodcast on Twitter or theradiologyreview@gmail.com. Keep up the good work and study hard. You have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.